Well, good morning, everyone. We'll get started. We know everyone's time is precious and busy. My name is Arnold Weinfeld. I'm Associate Director at the Institute for Public Policy and Social Research at Michigan State University, and with our partners at the MSU Institute for Health Policy, along with the generous support of the Michigan Health Endowment Fund, we are able to continue these health policy issue forums moving forward for legislators who are involved in health policy and healthcare committee work in the Michigan legislature. Today's session is on Medicaid 101 session, and to introduce our speakers, I now have the pleasure of introducing Kathy Stifler from the MSU Health Policy Institute. Kathy.
Good morning, everyone, and thank you for joining us today. Arnold and I have been meeting with the legislators to identify their priority needs around the topic of health policy. And Medicaid 101 has come up very often. As anyone who has either worked in or worked with Medicaid knows, it is an incredibly complex program to understand and has such far-reaching implications for policymakers, both legislative health policymakers as well as state health policymakers. And so we thought, since the Medicaid budget was recently presented to the legislature, that this would be a good time to follow with some basics and for also to introduce some national topics that we'll introduce at the end of the session. So to start off today, we're going to start with our state Medicaid director, Kate Massey. Kate is the Senior Deputy Director for Medical Services Administration with the Michigan Department of Health and Human Services. She's been in that role since June of 2019. In that role, she also serves as Michigan's Medicaid Director, overseeing several health programs, including My Child and the Healthy Michigan Plan. Director Massey has 20 years of operational and policy expertise in Medicaid, Medicare, Children's Health Program, and the private market health insurance program. So I'm going to turn this over to Kate. We will take questions periodically through her presentation, and then again at the very end of the session. Thanks, Kate.
And one more thing, Kate, before you get started, please use the Q&A box to ask questions as the presenters move forward, and Kathy and I will be monitoring that, and at appropriate time, we will get those questions answered. Kate, just let me know when you want me to share the screen and you can get going.
Yeah, let's kick it off. Fantastic. So if we could skip to the slide talking about the types of government assistance, that'll get us going. And while the slides are moving, I just want to thank Kathy and Arnold and everyone at the forum for having MSA at this morning session. Really excited to be talking to you about Medicaid 101. This is obviously something that we all feel super passionately about. I've spent a lot of time working on Medicaid in particular, but public programs more generally. So what I thought would be helpful to warm us up is to really kind of talk about the spectrum of government assistance available throughout the country. We're talking today about Medicaid. Medicaid is a program designed to support low-income individuals, majority children, pregnant women, seniors, and persons with disabilities. Medicaid is jointly administered by the states and the federal government, and we're going to spend a lot of time talking about that relationship this morning and exactly what the dynamics are, where states have authority and are able to kind of set vision and innovate versus the support that the federal government provides us when it comes to day-to-day administration of the program, but also high-level policy. But Medicaid is not the only government assistance available. So want to talk about other programs that will likely be referenced in comments later on so that we're all kind of clear on how these programs are different from one another. So the second program I want to talk about is the Children's Health Insurance Program. This was a program that came about, I think, in the late 90s. CHIP was designed to wrap around Medicaid. So it covers children and pregnant women at a higher level of what Medicaid had been providing coverage to. And when I say higher level, I mean a higher income level, But there are a couple of design elements of CHIP that are different than Medicaid. First is that it has a higher federal reimbursement rate, so the financing structure is a little bit different. The higher reimbursement rate was put forward as an option to states because they wanted to, the federal government, Congress, wanted to entice states to take up CHIP. All of these programs, Medicaid, CHIP, they are all state options. And so in order to make sure that states were kind of excited about the ability to expand coverage to kids and make sure that the financial burden wasn't exorbitant, there is a higher reimbursement level in the CHIP program. The benefit package for CHIP is a bit different than Medicaid. It can be more streamlined and it can be slimmer depending on what state's decisions are. One of the key differences in the CHIP program is that there is no comprehensive screening and diagnostic testing requirement for benefits, and we're going to get into that a little bit later. And then CHIP is also financially constrained. So there are CHIP allotments that are designated state by state, and a state must manage its budget within a particular CHIP allotment. So a lot of design differences between CHIP and Medicaid. The other government assistance program worth mentioning where there is a fair amount of overlap and interaction with Medicaid is Medicare. Medicare is most well known as an insurance program for seniors 65 and older, but Medicare does not exclusively cover seniors. So you can be a person with a disability and receiving Medicare services. You can also be someone who has end-stage renal disease and you can receive Medicare services. If you are on the disability spectrum and a Medicare recipient, it's because you have been designated as having a disability per the Social Security Administration. That is an SS or Social Security definition that people must qualify for, and you must receive benefits on your disability insurance from the Social Security Administration for at least 24 months before you are eligible for Medicare. Medicare also has a work requirements component to it. So individuals receiving Medicare must have worked in the workforce for at least 40 quarters. And so if you have not reached the 40 quarter mark and you are a senior, you might have coverage in Medicaid, you might not have coverage in Medicare. So there are differences in terms of qualifications for both Medicaid and Medicare for certain classes of people based on this work requirement element. Medicare is federally administered, so there are national coverage standards. There really is no regional variation except when it comes to reimbursement. In the case of reimbursement, there may be instances where CMS will take into account regional variation and the economics of a particular region in order to make slight modifications to base level reimbursement to providers. But that would really be the only place where Medicare has a fair amount of variation. And then the last type of government assistance, which is relatively new because it came out of the Affordable Care Act, are health insurance subsidies. So health insurance subsidies are provided to individuals if you're in an expansion state above 139% of the federal poverty level. They defray the costs of commercial insurance. So commercial carriers provide offerings on an exchange. An exchange is basically a health insurance marketplace that can be administered by either the state or the federal government, depending on state choice. And those individuals have the choice of their commercial carriers while getting some federal monies to defray their monthly premium costs. The really important component of exchanges, and one of the things that was really notable about the Affordable Care Act, is the notion that people with pre-existing health conditions, so people who might have chronic care needs, who might have struggled on the individual market before the ACA, are guaranteed coverage through the exchanges. So this was kind of one of the major shifts in how insurance is handled pre and post. So if we go to an introduction of Medicaid, and then Arnold, if you don't mind flipping to the next slide. So an overview is that Medicaid and Medicare were both authorized in 1965. Medicaid is established and its policies are grounded in Title 19 of the Social Security Act. So if you hear a lot of 19s going on, and we'll talk about that later on the waivers, that's a reference to what section of the Social Security Act Medicaid is governed by. It is means tested. It covers by and large children, families, seniors, persons with disabilities, and pregnant women. And it is a huge program. It has a huge amount of impact throughout the country, but also within Michigan. Later on in the presentation, we're going to talk about how Medicaid and Michigan intersect, and you'll be able to see Medicaid's far reach. Next slide. So when we talk about the administration of Medicaid, there's a saying for people who have been around this policy space for a while. And the saying goes, if you've seen one Medicaid program, you've seen one Medicaid program. And the reason why is because states really drive a Medicaid program that best fits their state needs, their citizens, and oftentimes their budgetary constraints. There are three main areas where states exert the maximum flexibility, and that is around who do they cover, what benefits do they offer, and how do they provide those benefits. Medicaid will often set a mandatory benchmark or threshold, but states are able to choose options above whatever that minimum threshold is to best serve the needs of their community. There's a partnership between the states and the federal government. We'll talk a little bit more about that later on when we talk about the state plan amendment. That is essentially our contract with the feds. And the one thing that I will say about Medicaid, and this is another reason why there is so much program differentiation, is that Medicaid consumes oftentimes a fair amount of state budgets and is subject to a lot of pressures to make sure that it is being run efficiently and that taxpayer dollars are being held and guarded by not only state legislatures, but also by Medicaid agencies that run those programs. And so because of that, there is a fair amount of innovation that occurs in the Medicaid space because there is usually a constant pressure to make sure that we're stretching our Medicaid dollars as far as they can possibly go. I want to spend a little bit of time talking about Medicaid eligibility, and this is going to be pretty high level because Medicaid eligibility is one of the most complicated elements of the program. By and large, Medicaid has pathways, and so you've heard me talk about some of the eligibility pathways that I've mentioned up till this point. Being a child is an eligibility pathway. Being a person with a disability is an eligibility pathway. There, as I mentioned, are mandatory thresholds that states may set. So in the case of kids, let's kind of talk through an example. The statute would say that kids age 1 to 5 must be covered if a state opts into Medicaid up to 133% of the federal poverty level. But that being said, a state can also extend the income for eligibility for a child age 1 to 5, maybe up to 185% of poverty. So there's a lot of flexibility in terms of how coverage is provided. Eligibility is considered on a couple of different dimensions. We talk a lot about income. So when we're talking about the federal poverty limit and a percentage associated with the federal poverty limit, what we're talking about is how an individual or a family's total income compares to that federal poverty limit, which is established by the federal government. So it is a standard by which we have to assess. It is updated annually, and we assess eligibility relative to that income standard on an annual basis. Eligibility can also be and can also consider assets. And so there are both resource/income and asset tests depending on how you are trying to qualify for Medicaid. Back in the day, there was a really strong linkage between Medicaid and welfare, or AFDC. So when welfare reform came along, and I think it was like the mid-90s, that really strong linkage between Medicaid and welfare reform and welfare was broken. Prior to welfare reform, eligibility for Medicaid and for welfare were actually linked. So if you were a parent, for example, trying to apply for Medicaid and you qualified for Medicaid, it was the same definition, the same standard as receiving and accessing welfare benefits. Post-welfare reform, that linkage broke. And you'll see that some of the different eligibility levels, when you look not only in Michigan, but across states, will be variable because we grandfathered in the welfare eligibility levels at the time of welfare reform. And there's a slide later on that kind of speaks to that really acutely. And then the last thing I'll say is that on eligibility, childless adults prior to the Affordable Care Act were not eligible for Medicaid benefits. And I think that this could sometimes be a common misconception that anyone who's low income could achieve Medicaid eligibility just based on the fact that they might not have had a lot of financial resources available to them. Childless adults, basically people who were not qualifying for one of those pathways that I had talked about before, could not receive Medicaid benefits until the Affordable Care Act introduced the Medicaid expansion option. And so we'll talk a little bit about how that impacted Michigan again later on in the presentation. So if we go to the next slide, which is about Medicaid benefits, there are mandatory services and there are optional services. So the same framework of mandatory and optional, just as it applies to eligibility, also applies to benefits. Some of the mandatory services I think are a bit intuitive. You have access to see a physician. You have access to go to a hospital if you need it. There are a few benefits, however, that are specific to Medicaid that you don't necessarily find in the commercial market. So EPSDT is one of those benefits that is a quote unquote Medicaid special. EPSDT stands for Early and Periodic Screening, Diagnostic and Treatment Services. It is a benefit that applies to children 21 and under. And essentially it compels physicians who are doing mandatory well child visits to screen children for any developmental delays or any other health needs that the child might have. And if through a screening process, an additional need is identified, whether that be speech therapy, physical therapy, occupational therapy, those are just examples, then the benefit of EPSDT provides the child that gateway to the follow-up services. So oftentimes EPSDT is considered a bit of a gateway benefit. It screens comprehensively, and to the extent that there are additional needs, the services attached to those additional needs are automatically provided. They are an entitlement to a child receiving an EPSDT service. The other thing that sets Medicaid apart from traditional commercial insurance is that we have much more of an investment in long-term care services as well as behavioral health services. So in Medicare, there is a very limited nursing home benefit. Oftentimes it is restricted to rehabilitation after a surgery. So if we were to take a real life example, a senior might fall down, break their hip, they might have to go into a nursing home in order to get some rehab support. Medicaid would pay that for a time limited period, after which Medicaid would assess whether or not they need to continue to provide wraparound services. There are individuals who need to remain in long-term care facilities for a long time because their needs are so severe. And if that occurs, those individuals are considered to be receiving custodial care, which is to say the nursing home serves as their home. Medicaid is one of the only payers, I think it is the only payer in the country of long-term custodial care. So basically we support in congregate care settings, individuals who are treating those congregate care settings as their home. And the reason why the nursing home serves as their residence is because they oftentimes need so much assistance with activities of daily living, or ADLs. And Medicaid has a benefit called personal care, which helps individuals manage through those ADLs, which is to say that providers are helping with toileting, bathing, feeding, dressing. And while those personal care services can be provided in the nursing home, they can also be provided in the community. And we'll be talking a lot about home and community-based services in the long-term care setting. One of the huge drivers of home and community-based care setting services is this personal care service, right? Helping individuals go about the daily activities of their life in order to stay in their community. Community-based behavioral health services are an additional service that is Medicaid-centric and Medicaid-heavy that does not usually occur in commercial products. We'll talk a little bit later on about the types of community living supports that behavioral health can provide. But there are real differences in terms of what Medicaid can do to wrap around that is unique to this particular program. The other thing that I think is important to note on this slide is that we actually do have references to providers as well. So Medicaid has a provider network that is oftentimes very different than commercial because we are using community-based providers as the backbone of how we provide services. An example of that is federally qualified health centers. So FQHCs are community health centers embedded in our communities. They really are the engine for providing a lot of preventive care and Medicaid support to our Medicaid beneficiaries. FQHCs are unique because they are kind of co-authorized or co-managed by the federal government. So within HHS, there is an administration called HRSA. HRSA has oversight over FQHCs. And there are requirements of FQHCs to make sure that there is a good synergy between their mission as well as Medicaid's programmatic objectives. They are required to serve underserved areas. They receive enhanced reimbursement to do so, and they must be embedded in the community. So there are different requirements around their governance structures to make sure that they are very attuned to the needs of the community in which they provide services and serve. And then you'll also see that Medicaid provides reimbursement for things for providers such as freestanding birth centers and so on. The Medicaid provider network can be a bit challenging because when we think about reimbursement, Medicaid is typically at the lower end of provider reimbursement levels. The kind of spectrum or continuum usually goes that Medicaid pays the least on the spectrum, Medicare is in the middle, and commercial usually pays above Medicare. So that is kind of generally how reimbursement flows. And because Medicaid can be a bit tight in how much reimbursement it provides, oftentimes providers are making a decision about whether or not they want to participate in this space. We do have, for example, nursing homes that decide not to participate in the Medicaid program. And that goes for essentially every provider class that comprises a Medicaid network. So if we go to the next slide, we're going to talk a little bit about waivers. So I talked a little bit before about the joint administration of the program. And the contract that the states have with the federal government is called our state plan. That essentially outlines all of the rules for what the state is allowed to provide in terms of eligibility, benefits, and delivery system. If we want to make a change to that contract, which we can do at any point in time during the year, that would be called an amendment to our state plan, a state plan amendment, or a SPA. You might actually hear that referenced in conversation. SPAs must be approved by CMS before they are implemented. So there is an order to how CMS prefers that changes be made to a Medicaid program. And there are also public comment and consultation requirements related to any change we make to the program. An example of that consultation would be with tribes. We have different tribal consultation requirements that we need to alert the tribes of Michigan to before making a change so that they're fully aware. This SPA process has been a little bit different in the period of COVID because the reaction and the response by states and the federal government to COVID has needed to be so real time and so nimble that CMS has provided states with some flexibility to move forward with key changes without getting approval ahead of time. So that has been one of the areas where CMS has shown us a fair amount of flexibility and leniency in making sure that we can be kind of our best when we respond to the needs of the pandemic. Another way that we engage in co-administration of the program with CMS is through the waiver process. And this is really where you start to see states really engage in a fair amount of innovation around how they run their program. So this concept is called a waiver because what we're really doing is we're deviating from the parameters that are set out in the Social Security Act. And there are allowances that the Social Security Act provides us to move away from the standards that Congress put into place. CMS has put parameters around their waiver policy because they don't want to waive all of the requirements. They want to waive them in certain areas that align with their own objectives, policy, budget, and otherwise. And so oftentimes we need to demonstrate the need for a deviation from the base statute. And we need to demonstrate to the federal government that we will not be spending more than we otherwise would have. There are different types of waivers. So Arnold, if we go to the next slide, we can talk through the different types. 1915B waivers typically align and correlate to flexibilities for managed care. They can also speak to, as is referenced in the slide, enrollment brokers. We can provide some enhanced benefits, but 1915B typically means managed care. 1915C usually refers to home and community-based care. So that was what I was mentioning before about making sure that field-based and community-based services are provided to bennies to make sure that they can reside there when they're aging or might have additional supports needed based on a disability status, for example. That is not allowed for explicitly in the statute. And so sometimes we need to ask for waivers or permission from CMS to be as expansive and as aggressive as possible in providing those HCBS services. And then the last waiver type is 1115. And these are the waivers and the demonstrations that get the most national attention. So there have been many flavors of 1115 waivers. When they first started being granted by CMS, oftentimes 1115s were a mechanism to expand coverage to individuals who might not otherwise be covered. So when I was talking before about how childless adults do not have an eligibility pathway to Medicaid, one of the ways that states could circumvent that prohibition was by using 1115 waiver authority. And essentially what the state would do is say, I am pursuing a modification to my Medicaid program that would generate so much savings that I can redirect those savings to provide coverage. There have also been 1115 waivers that get at Medicaid financing because there is a long history of how states have really tried to maximize and leverage federal funding. Some of those have been found to be impermissible after years of engagement there. So CMS has tried to transform some of those financing arrangements into something a bit more legitimate via an 1115. And Michigan actually has some 1115s that I want to talk about in greater detail. So if we go to the next slide, we'll see what waivers Michigan has. So as I was saying before, the 1915B waiver is really about managed care. So our comprehensive healthcare program, which is the major program that we have in Michigan that provides managed care services to our bennies, this is the program that is supported by our Medicaid Health Plans or MHPs. This is provided to the state via a 1915B waiver authority. We also have 1915C waivers in the way of habilitation supports, but sometimes those waivers can be combined depending on the design of the program. So if you see the third row talks about 1915B-C combinations, and there we see some of our more popular programs when it comes especially to long-term care services. So the My Health Link program is a program that serves dual eligibles. Dual eligibles are those who are receiving both Medicaid and Medicare services. Medicare, as we've talked about, it can be a more limited benefit. So the Medicaid specific services that we provide, whether it be behavioral health, personal care services, they can wrap around the core Medicaid benefit. And that is the benefit that dual eligibles have. They receive the base level services that Medicare provides, like hospital, physician services, prescription drugs, what have you, but those Medicaid specific benefits are provided by our program. The My Health Link waiver actually integrates both. So there is one managed care entity, one provider that is providing both sets of benefits, and hopefully to the beneficiary, and we've found this through surveys and stakeholder engagement, the beneficiary is blind to which program is providing the type of service that they need. And that is really what the My Health Link program is trying to do. It's trying to integrate these two programs so seamlessly that the beneficiary is just served by one health plan that provides everything that they need in their personal continuum of care. The other long-term care program that's particularly important is the My Choice program. So that is run by our waiver agents. Most of those are AAAs. They serve as the waiver agencies providing the My Choice benefit. The My Choice benefit provides those HCBS services, the personal care services, home health, services provided by an RN in the home. They provide the entire array of what an individual needs to stay in their community so that they don't degrade and need to receive their services in an institutional setting. My Choice is the alternative to nursing home-based care. And then when it comes to 1115 waivers, Michigan has several. The two that I want to focus on are Healthy Michigan. So Healthy Michigan was essentially our vehicle for adopting the Medicaid expansion. This was the Medicaid expansion made possible by the Affordable Care Act. Our Healthy Michigan plan had design elements that wrapped around the base level expansion. You can hear about work requirements or healthy behavior requirements. Those were pursued, and we were able to pursue them via the 1115 waiver. We also have a waiver that responded to the Flint water crisis. So the Flint waiver actually, by and large, targets CHIP funding, which is kind of the allotment that I was talking about at the outset. It redirects CHIP dollars to kids up to the age of 21, up to 400% FPL, as well as pregnant women, and it provides them targeted case management as well as other support services. The design concept that makes Flint particularly interesting is that it's a benefit that impacts people who were personally affected by the water crisis in Flint. If they move to other areas of the state, the benefit follows them. So whereas the intervention was targeted to Flint, the benefit expands beyond that geographic region, but follows the individual. And so that is a little bit different. And it allowed us to kind of explore an innovation that was different, but also met the needs at the time. So if we go to the next slide, we're going to talk and pivot a bit to Medicaid financing. So just like the program is co-administered by states and the federal government, It is also funded jointly by states and the federal government. The federal medical assistance percentage is the percentage at which the federal government provides support to the overall program spend. And we're going to go through the different types of reimbursement that the federal government provides to us, because it can vary based on type of activity or type of service. The FMAP is updated annually, and there is a formula that is included in statute that ties the FMAP calculation to per capita income. So to the extent that a state has low per capita incomes, it has a higher FMAP, a higher reimbursement rate. To the extent that a state is wealthy, the lowest that an FMAP would be is 50-50. So if you look at wealthier states such as a New York or a California, they have a 50% FMAP rate. Ours is higher in Michigan, and it's detailed actually on the next slide. So here we can see how the FMAPs impact Michigan specifically. Right now, our FMAP rate is above 70%. There's an asterisk next to this because our FMAP is actually being modified as we speak as a result of the COVID pandemic. So for one of the first COVID relief packages that Congress passed, there was a provision in that relief bill that increased all states' FMAP percentage by 6.2 percentage points. And so that's what gets us to our 70.3% FMAP rate, which is our current FMAP rate. One of the issues is that when the federal government gave us the FMAP bump, which was intended to provide state relief to us because we were expecting budgets to be constrained as well as financial needs to increase because of the pandemic, they did so with the requirement that states not reduce eligibility. So not only were we prohibited from reducing eligibility levels, but we actually could not engage in any redetermination activities in order to receive the 6.2 percentage point increase. And so that is something that we're going to need to talk about when we start to emerge more definitively from the pandemic, because there is a backlog of redeterminations that we will need to tackle. I had mentioned before that the CHIP program has a higher FMAP percentage because Congress wanted to entice states to adopt CHIP expansions. And so you'll see in Michigan, we're at 79% for our CHIP FMAP rate. And then when it comes to the Healthy Michigan plan or our ACA expansion, Congress did something similar to CHIP in trying to entice states to adopt the expansion. They actually started with an FMAP rate of 100%, and it gradually phased down to a steady state of 90%. So into the foreseeable future, anyone who qualifies via Healthy Michigan, we get a 90% offset for every dollar spent to support our beneficiaries receiving coverage via HMP. For administrative services, there can be different types of reimbursement. For kind of the standard admin, we get 50%, but there are different categories of enhanced activities that CMS will provide 75% reimbursement for. So examples of those enhanced activities might be nursing facility surveys or inspections, or quality activities, quality oversight. Those receive a little bit of a sweetener because they're important. And then lastly, we have Medicaid IT services, which can vary between 75% and 90%. By and large, new development in our IT activities receives 90% reimbursement. Arnold, can we go to the next slide? Great. So let's talk a bit about Medicaid in Michigan. And I know I'm running a little bit short on time, so I want to move through this relatively quickly. So
before you start, can I just remind people that if you do have questions, if you could put them in the Q&A section, and we will get those as we can or at the end. Thank you. Go ahead, Kate.
Thanks,
Sorry to
Kathy. Okay, so Michigan has definitely taken advantage of Medicaid and its services. So Arnold, if you go to the next slide, you can see how much it has impacted the state. We've got about 2.5 million Michiganders receiving Medicaid that is driven by children, but we also have a significant number of adults receiving coverage through the Healthy Michigan Plan. And if you flip to the next slide, you can see two things. One is the heat map on the right-hand side, which basically shows that Medicaid impacts Michigan pretty consistently, right? That is the density of Medicaid beneficiary by county level. And if you actually look at the eligibility pathways we were talking about before, 1 in 5 adults are covered by Medicaid, 3 in 8 children, 3 in 8 individuals with disabilities. So it shows the reach of Medicaid into all of our communities. If you go to the next slide, we'll talk here a little bit about the eligibility pathways that I was talking about before. The green shows pre-Healthy Michigan. And in particular, if you look at the columns of parents or caretaker relatives, 19 to 20-year-olds, you'll see variation in the green. Those are the AFDC levels that were codified. Then you see HMP taking everyone up to 139% of poverty. And then you see the exchanges covering everyone up to 400% of poverty. So this is a continuum that I had talked about before that now you can actually see visually. If we go to the next slide, this kind of talks about how the budget breaks down. And there was always a rule of thumb that seniors and persons with disabilities would account for 1/3 of the population, but about 2/3 of the cost. That has changed with the inclusion of childless adults as a population. So now you'll see that seniors and persons with disabilities are about 17% of our total population, but account to close to 50% of our spend. And that just shows that because those individuals are higher needs, they need and utilize more services in order to make sure that we are focused on their care and their quality of life. If we go to the next slide, you'll see here which buckets or categories of services really drive the overall Medicaid budget. So hospital care is one, but then you'll see that the Medicaid specific benefits that I've been talking about in the long-term care space and the mental health / behavioral health space really take up a significant part of our budget. And one of the reasons for that is because these are Medicaid only benefits or Medicaid primary benefits that we provide. And so you'll see it reflected here in our total spend. Can we go to the next slide? And then here is, I think, the constant pressure that legislatures and Medicaid agencies constantly feel themselves put under. This shows the growth in healthcare spending, and there is a huge deviation here between what commercial carriers and Medicare experiences in the way of growth. Those lines are the yellow, blue, and red lines that you see steadily increasing. What you see on the bottom, which is the green or aquamarine line, is Medicaid. And Medicaid grows at a much slower pace, and its growth is more controlled. One of the reasons for that is that we are constantly focusing on efficiency and innovation, and we have much more cost pressure that compels us to grow at a slower pace than these other programs. Next slide. Okay, and then let me talk about the Medicaid delivery system, and then I'll pause again for questions or some conversation. Next slide. The Medicaid delivery system basically has kind of multiple ways of providing the care to our beneficiaries. Managed care is one of the primary vehicles that we have used in Michigan to provide services. And essentially what the state does by adopting managed care is that we delegate administrative functions but more importantly, care coordination functions to health plans to manage on the state's behalf. And the value proposition of managed care is that we transfer financial risk to health plans, and in return for the health plan adopting the financial risk, they also have the motivation to provide efficient care, which gets to our slow growth rate, as well as high quality care. And the way that we transfer the financial risk is through a mechanism that we call a capitation payment. So with the help of independent third-party actuaries, what we do when we're engaging in managed care programs is that we estimate the average spending of individuals who are enrolled in a managed care program. And we then kind of take the monthly average of spend, provide that to a third-party entity to manage and provide care. That means that they're providing reimbursement to providers for all of the services, but they're also providing value add benefits like care coordination. Sometimes they might provide enhanced benefits. They can provide transportation. They will focus on member engagement and outreach to make sure that people are going to the doctor, seeing their doctor. They really want to make sure that they are getting their quality scores up and maintained, because that is something that the state will look at as a key metric of performance and success. And so once the capitation payment is made to that managed care entity, to the extent that their total costs exceed the capitation payment, then the health plan or the managing entity is at risk. That means that they basically eat any overage above average spend. To the extent that through the provision of efficient care, that managed care organization spends below what the capitation payment is, then they get to keep that difference as, I guess you could say profit, but a lot of times what the health plans are doing is reinvesting those dollars into our state, into our program, and into our beneficiaries. So in Michigan, we have a fair amount of variety when it comes to our Medicaid health plans. This is our largest managed care program. So there will be national insurance companies, national carriers, such as like a United or a Molina or a Centene participating in our program. But we also have a fair number of health system affiliated health plans. So Priority Health Plan, for example, is affiliated with Spectrum. McLaren Health Plan is affiliated, obviously, with McLaren Hospitals, and so on and so forth. So that really kind of gets to a fair amount of beneficiary choice that they can exert when they're enrolled in Medicaid and when they are given the option to choose which health plan best suits their needs. What beneficiaries are often choosing from is an alignment with their care philosophy, the expansiveness of the benefit or of the provider network, and any enhanced benefits that the health plan might offer. Managed care also applies to some of our long-term care programs. So the My Choice program, which provides home and community-based services, is managed by AAAs as well as some other organizations. Those are managed care entities, right? They receive capitated payments just like the MHPs. They do it on a smaller scale and the benefits are different, but that still is a managed care delivery system. If we go to the next slide, we'll talk a little bit about fee-for-service. So fee-for-service is essentially analogous to a PPS network. So beneficiaries can receive services based on who is a participating Medicaid provider. The Medicaid provider engages in a fee-for-service world most with the state Medicaid agency, or MSA in our case, because we are the ones who are paying the claims. We are the ones who are providing the enrollment to that particular provider. So we don't have much in fee-for-service, but not everything can be in a managed care environment. And so fee-for-service will always be an element of our overall Michigan Medicaid program. And then the last thing I wanted to talk about, and then I'll pause for questions, is behavioral health. So the behavioral health network on the next slide is different than what I've been talking about on the acute care services and long-term care services, there is an entire network stitched together of community mental health providers, CMHs. So the CMHs are, in a sense, analogous to the FQHCs. They are community embedded providers who are exclusively offering behavioral health services to individuals. Anyone who is referred over to the behavioral health system usually has higher needs. So if an individual has a quote unquote mild to moderate behavioral health need, they will be served by Medicaid Health Plans. If they have a serious mental illness, they are served by the CMHs, who are managed by the prepaid inpatient health plans, or the PIHPs, which are the managing organization. So a PIHP would be analogous to a Medicaid health plan. They are the ones that are erecting the provider network, paying the claims, doing the provider enrollment, and so on and so forth. The CMHs are the entities that are on the ground providing the services to individuals in need. So I think we're at, Kathy, another natural breaking point. I have a lot more slides, but I'm almost wondering if we should stop here and I can turn it over to Jack, who's going to talk about federal trends, and then we can kind of see if there's any time for conversation later on.
Before we turn it to Jack, Kate, we do have a question that I'd like to ask you before we move on, because it's relevant to something that you were just going over. And from a senator, how's the Medicaid 95% reimbursement dispersed to state? Is it over several fiscal cycles? What is the actual reimbursement breakdown? So is that something you can answer, or we can follow up following as well?
Yeah, so we can follow up for sure. I mean, the way that the federal dollars flow to us is through a regular reimbursement cadence. So we provide to CMS an accounting of all dollars expended. We do that through a vehicle called our CMS 64. And I believe, and Kathy and Jack, you guys can correct me, I think we get the reimbursement on is it a quarterly basis or a monthly basis?
Honestly, I think it's quarterly, but we
I think
need to
it's
double check.
quarterly as well.
I think it's quarterly too. Yeah, I think it's quarterly.
Okay. The only other question, Kate, that's come up is you described the waivers, and a senator has asked, can anything be waived? Any Medicaid rule be waived, or are there only certain rules that can be waived?
So there is, especially with the 1115 waiver authority, pretty broad discretion allowed to CMS. The one element that HHS's OGC has said absolutely cannot be waived is reimbursement levels. So through an 1115 waiver, CMS cannot deviate from the FMAP or any of the other statutory reimbursement levels, whether that be for administration or IT that I was talking about. That there's no daylight there in terms of moving off of reimbursement.
And I recall when I was with the program, there was desire to increase the percentage cost share for the beneficiaries, and there is a limit of which CMS will allow for the states to ask for a cost sharing responsibility, for example, in the Healthy Michigan program. Okay, so I think I'm hearing you, Kate, say rather than continuing with your slides, you would like us to turn it to Jack, and then maybe you can, if we have time at the end, you can wrap up with some of the state initiatives. Is that how you'd like to proceed?
That would be great.
Okay, great. So Jack Rollins is joining us today from the National Association of Medicaid Directors, and he's been with that association since April of 2014. He is responsible for the association's policy work, including analysis of legislation and regulations impacting the Medicaid program, convening Medicaid directors and their staff to identify and build consensus around policy objectives and articulating members' consensus positions to the federal policymakers and Medicaid stakeholders. So Jack, I'll turn it over to you. Thank you for joining us today.
Well, great. Thank you for the opportunity, and I am glad to be here. So before I begin, I just want to acknowledge Kate's leadership as a Medicaid director here in Michigan, and wanted to note that she is going to be joining NAMD's board of directors on effective April as one of the representatives for the Midwest region. So congratulations to Kate. And wanted to just call out her leadership role with the association. So I'm Jack Rollins. I'm the Director of Federal Policy at the National Association of Medicaid Directors, or NAMD. Just a quick bit of context about the association. We've been around relatively young, been around since about 2010, shortly after the Affordable Care Act was passed. We were initially convened to focus on federal policy matters and elevate the perspectives of Medicaid directors to federal decision makers in both the administration and in Congress. Since then, we've also expanded our footprint to facilitate some state-to-state learning on operational issues in the Medicaid program. As you've seen from Kate's presentation, the Medicaid program is very complex, and there are multiple different benefits and populations that it covers, each of which have their own unique kind of challenges to navigate. So we help states problem solve collectively on some of those issues. And then lastly, we also have a leadership development portfolio for Medicaid directors and their senior teams to equip them with the skill sets necessary to run what is essentially a Fortune 50 health insurance company, given when you think about the size of Medicaid program budgets and the budgets of other payers. So that's in a nutshell NAMD and who we are. So Kate's given a very good background already on kind of the high level structure of the Medicaid program, as well as some of the Michigan specific aspects of the program and how Michigan is administering it. So I'm here to provide a little context on some of the federal Medicaid issues and the direction that we're anticipating federal Medicaid discussions taking over the next couple of years. I also want to make sure that there is some time for Q&A at the end. And so similar to how folks have been doing already, please, if anything, if there's anything that strikes your fancy and you'd like to learn a little more about, drop a question in the Q&A and we will be happy to answer it. I want to touch primarily on the ongoing response to the COVID pandemic, as well as the role of value-based purchasing and targeting social determinants of health in Medicaid, with some time also on the long-term services and supports, or LTSS, and some behavioral health topics. So beginning in that order, of course, top of mind is the COVID-19 pandemic. So we are now a year into the pandemic. It's had a huge impact on Medicaid populations and providers, the Medicaid program writ large. What we saw, especially in those early months of the pandemic, is that Medicaid programs were able to act very quickly, very nimbly to respond to the pandemic, using both some rapidly available federal flexibilities, as well as some federal resources, such as the congressionally appropriated federal match enhancement that Kate mentioned, along with some state level work to ensure that the viability of the Medicaid provider infrastructure, all the various provider types that are serving these various populations, would remain fiscally stable, if not completely whole, during the pandemic, as well as maintaining safe access to services for the populations that really needed them. I think one of the lessons that we learned is that states could move very quickly when circumstances called for it. And in fact, I recall in the early days of the pandemic, many states were implementing policies that had been rapidly developed and oftentimes outpaced the development of federal guidance or parameters on various topics in which states were taking action. And we did that with the blessing of our federal partners at the Centers for Medicare and Medicaid Services, or CMS, which is the primary federal entity that oversees and regulates the Medicaid program. So all of that was completely necessary at the time. Now that we've been living with this for a longer period of time, and we've seen federal parameters put in place and even shift and evolve as the pandemic itself has evolved, we're of course in a different circumstances. But thinking about the provider sectors that have been hit particularly hard in COVID, I think top of mind is the long-term care sector. It had we all know the headlines. There was a terrible mortality rate among caregivers and individuals residing in institutional care settings. That's a whole topic unto itself, which I'll talk a little bit more about later. But we also saw dramatic impacts on service utilization across the board for all types of Medicaid providers, whether that was primary care, pediatricians, behavioral health providers, the transportation providers that take individuals to their doctor's appointments. We saw it in a variety of others. That's not an exhaustive list, but kind of the point stands that, especially in those early months of the pandemic, as we've started seeing the initial round of lockdowns and a real clampdown on sort of voluntary use or elective procedures and kind of really non-critical or non-urgent procedures, which are often a source of reliable revenue for a variety of providers, those all fell away. We saw that the rapid expansion of the use of telehealth in the Medicaid program was one way to kind of bring some relief in this, both in terms of keeping utilization somewhat elevated, as well as ensuring that Medicaid members could find new or different ways to receive the services that they needed. In terms of the telehealth footprint of the Medicaid program, the federal policy environment has always been very flexible for states to implement telehealth as they see fit. But it wasn't really until the pandemic that we saw this kind of across the board, across the nation uptake of telehealth in the Medicaid program. Prior to that, there were some states that were a little further along than others, especially common in states that had significant rural populations or tribal populations. But now we have seen that not only has telehealth rapidly expanded, provider types that had previously been somewhat, maybe a little more reluctant to take up telehealth, once they realized that that was their only option to remain viable during the pandemic, they of course did it. And now it's kind of here to stay. And that brings with it a new or different set of questions, such as how do we begin evaluating the quality of telehealth services that are being rendered? Are there certain telehealth modalities? So is there a difference between services that are provided through kind of an audio and a visual component, kind of like what we're doing here on a Zoom call, versus services that are rendered only via the telephone? Are there services where either thing fits, one where we should be preferring one modality over the other? How do we think about bespoke program integrity plans to ensure that telehealth services are being provided at a high quality and appropriately, are cost effective, they're being utilized appropriately, et cetera. But these are the things that Medicaid programs do for any benefit in the program, especially as there are new benefits that are brought on. And so we're just kind of transitioning from rapid expansion of telehealth because that's what is necessary to keep the system going, to a more sophisticated analysis of those services, which is a silver lining from all that we've gone through in the pandemic. But shifting back to kind of what we've seen happen during the pandemic, obviously there was significant amounts of federal policy and federal resources invested in the Medicaid program and in the healthcare sector writ large. The biggest piece, which Kate has already mentioned, is the 6.2 percentage point federal match enhancement that's in effect for the duration of the COVID-19 public health emergency, or PHE. That PHE is also paired with a continuous enrollment requirement, which Kate has also mentioned, under which states cannot actually terminate Medicaid coverage while the COVID-19 public health emergency is in effect. I think this is somewhat unique, actually, in terms of congressional FMAP enhancements that have been instituted in the past. So thinking back to the 2008 and 2009 and the Great Recession, there was that the stimulus package that was passed in that time did have a federal match enhancement for Medicaid programs, but it didn't have this type of continuous enrollment requirement. So it's really been a bit of a new ground for states. And when Congress first passed this enhancement, which was in last March in the CARES Act, I don't think anyone expected at the time that a year later we would still be in the public health emergency. And frankly, that we're probably going to be in the declared COVID-19 public health emergency for the remainder of this calendar year. A letter from the Biden administration to state governors essentially indicated that it was their intention to keep the PHE in effect throughout 2021. So we're looking at potentially almost two full years of this continuous enrollment requirement where individuals are not cycling off of the Medicaid program, even if their circumstances would normally require that to happen. So because of that, we're seeing states shifting from kind of a short-term, almost hands-on or manual intervention in their Medicaid eligibility systems, which are the mechanisms the states use to track who should be on the program and who should be cycling off, going from this short-term or manual processes to effectuate that policy to having to think a little more medium-term with some more durable investments in Medicaid systems to effectuate the ongoing continuous enrollment requirement. But there's also an open question of whether there's going to be a shift from the federal administration in how they're interpreting that continuous enrollment requirement. Because back in last October, under the previous administration, a rule was instituted where states had some flexibility not to terminate coverage except in very narrow instances, but did have some flexibility to move individuals from one type of Medicaid coverage to another type, where previously that was not how CMS had interpreted federal statute. That interpretation may change. So that's something that we're paying a lot of careful attention to, as it does have implications for how states will be handling those systems issues and how they'll have and what levers they will have available to manage ongoing costs within the Medicaid program. Another area that is definitely worth some focus is the role of Medicaid in the mass vaccination effort. So Medicaid is a key partner in ensuring a successful vaccine rollout. We recognize that public health agencies are appropriately taking the lead in this, and the vaccination is squarely a public health responsibility. However, Medicaid has a critical role to play in both informing public health decision makers around priority populations in the Medicaid program that may not have the best visibility to public health. And I think a key example of that would be some of the home and community-based services recipients that are often served through those 1915C waivers that Kate mentioned. They can also be served through other authorities, but that is the most common one. And they just don't have the same visibility, especially to federal decision makers or policymakers in the public health world, for example, at the CDC, that more institutional settings like individuals that live in nursing homes have. So Medicaid can play a very important role in educating decision makers around this population, which has the same level of care needs as folks who live in nursing homes, but they're simply receiving that care in their own homes or in community-based settings with a much more patchwork provider type that serves them. Medicaid also has an important role in ensuring that individuals or provider types that are providing the COVID-19 vaccine to Medicaid enrollees, so that could be physicians, but it could be nurses, physician's assistants. In some states, we've seen veterinarians doing this. Medicaid has a role in ensuring that those providers are properly enrolled in the Medicaid program so that they can receive payment from the Medicaid program for that service. And then lastly, Medicaid is also, of course, has to decide how much they're going to pay for that service. And that payment question is actually going to change a little bit on April 1 of this year, so really coming up in just a little over a week, because at that point, a provision in the American Rescue Plan Act that was passed by Congress and signed into law a couple weeks ago comes into effect, under which Medicaid vaccine administration costs will be fully borne by the federal government. And so that FMAP percentage for vaccine administration services will be set at 100%. The final piece that I want to spend a little bit of time covering on the topic of the COVID pandemic is thinking about what's going to happen when eventually the declared public health emergency ends. So we've already talked a bit about that FMAP enhancement, that 6.2 percentage point enhancement. That remains in effect through the end of the quarter in which the public health emergency is declared. So for example, if the COVID-19 emergency, say, ended today, that FMAP enhancement would end at the end of this month because that's the end of Q1 of 2021. Of course, that's just an illustrative example. But what that means for states is that we do have to be thinking about how many federal resources are going to be available and how many are going to fall away when we no longer have access to that 6.2 percentage point enhancement. And then there's the question of exactly when does that enhancement fall away? So we have assurances from the administration that the PHE is going to last through 2021. And at a bare minimum, 60 days advance notice will be given. But that still makes the forecasting and budgeting exercise a little bit uncertain. We know that there are some Medicaid agencies and CFOs that have kind of budgeted through 2021 on that, with that 6.2 percentage point enhancement in place. Others aren't. But post 2021, it becomes murkier. So that does create an element of uncertainty for that budgeting. We also know that because of that continuous enrollment requirement that I mentioned earlier, there's a number of Medicaid enrollees who may have cycled off the program or whose income levels have changed during the PHE, but because of that enrollment requirement, remain on the program. So states will have to do some redeterminations, Medicaid renewals. Those usually happen on an annual basis. So again, because we're going to be in this PHE for almost 2 years, this, as a matter of course, is going to happen for the Medicaid populations. And there's going to be a significant amount of administrative work that's going to have to happen within the states to get all of that accomplished. We are hearing from our conversations with states that that could take anywhere from 6 months after the PHE to maybe a full year, depending on the sophistication of the state's eligibility systems. And it is, and similar to the interpretation of the continuous enrollment requirement, there is current guidance from CMS that was promulgated by the previous administration that envisioned a 6-month time period for states to complete this eligibility and renewal redetermination work. That timeline and the CMS's expectations within that timeline may also be subject to change. So that's another significant element of uncertainty and a bit of concern, as there's just a lot of catch up that's going to have to happen when the PHE does eventually expire. So in the interest of time, I'll kind of wrap up on the COVID-19 topic there and move on to the topic of value-based purchasing and social determinants of health, or SDOH. So a longstanding priority of NAMD and our members is continually innovating on the delivery of care and delivery of value in the Medicaid program. So as Kate so aptly covered, Medicaid spends billions of dollars, both state dollars and federal dollars annually. And as public stewards of those dollars, we have a responsibility to ensure that they are spent wisely. So the move away from a volume of services and kind of a volume-based reimbursement methodology towards the value of services provided, both in terms of healthcare outcomes or overall costs, is that is a cross-sector effort. Commercial payers have been invested in it. Medicare is invested in it. Obviously, Medicaid is invested in it. And we are all collectively working through a variety of program mechanisms and interventions to achieve some of those goals. But we've also seen as a running theme through this work is that there's the impact of all these non-healthcare factors or the social determinants of health on health outcomes, like stable housing, reliable access to healthy food, education level and education attainment, etc., like level of employment. All of these things are suggested by the healthcare and health policy research to potentially have more of an impact on health outcomes than the direct medical services that health insurers cover. And this is obviously very important for the Medicaid population. It is, as the Medicaid program is by definition and by statute and intent, targeting low-income populations that likely have a confluence of social determinants of health needs. That being said, Medicaid is also by statute and design a health insurer. Generally the purpose of the Medicaid program is to pay for actual medical services. There are some limits to what Medicaid can pay for that could be construed as social determinants of health. Admittedly, there are significant flexibilities, but there are also some limits. So for example, Medicaid can't pay for room and board, can't pay for rent, but there are, for certain populations and through certain avenues, Medicaid may be able to get the ball rolling, such as paying for a security deposit for an individual to get their own apartment. Might be something that's pretty common in the home and community-based services world, where an individual with a physical or intellectual or developmental disability would like to reside in their own apartment and have supportive and wraparound services financed by the Medicaid program. And part of the thing that Medicaid can do to help that individual is cover their security deposit for that setting. But I think more fundamentally, kind of not just looking at what can Medicaid pay for versus what Medicaid can't pay for, is that Medicaid can actually kind of play a leadership or convening role in identifying some flexible sources of funding through public or private sources to interweave into a kind of a braided funding package that can meet multiple needs for the members that are served by the program. So again, Medicaid might not be able to pay for housing, but there may be some synergy with housing and urban development programs through Section 8 housing vouchers or other programs to create that linkage. That's a coordination function that Medicaid can't accomplish alone or by itself, but it is something that can be done in partnership with other state level entities. And we've also encouraged our federal partners at CMS to partner with agencies like Housing and Urban Development, the Substance Abuse and Mental Health Services Administration, the Health Resources and Services Administration, et cetera, to have this kind of blended or braided funding approach interwoven federally and have that kind of dispersed to state level and even local level funding arrangements. But then shifting gears a little bit back to kind of that, what can Medicaid pay for versus what Medicaid can't. CMS has provided in recent months some what I view as very helpful guidance documents to the states on ways that Medicaid can target social determinants or pursue some common payment reform initiatives through the various state plan authorities and waiver authorities available to the program. Again, some of these are limited to specific authorities that serve specific populations, and I think probably the most common ones in the social determinant space, again, are probably within that home and community-based services waiver platform. But we think that that is a very helpful foundation to help states identify additional opportunities in this area, and also foster an ongoing dialogue with our federal partners to see if we can identify additional flexibilities for states to continue to support innovation and creativity to better meet the needs of the members that the program serves. So we also know that this is a pretty significant priority of the current administration. So it looks like there is kind of an open door or a good opportunity for states to come forward with some initiatives that they would like to see accomplished and kind of test the waters and the appetite to get that done. So recognizing that we only have about 10 minutes left, I'll move on to the LTSS item. So this is the long-term services and supports and long-term care piece. Medicaid is essentially the de facto long-term care insurer in the nation. As Kate covered, the Medicare's nursing home benefit is pretty limited. There really is no functional private insurance market for long-term care. The last time that one was attempted to be created through federal statute was a kind of a portion of the Affordable Care Act called the, I believe it was the Class Act, and essentially it didn't work and was soon repealed. So that essentially leaves Medicaid as the default payer of the nation, of the majority of the nation's long-term care spending. And again, as Kate covered, Medicaid has the nursing home coverage as a mandatory benefit in federal statute and can use waivers to provide that nursing home level of care in the home or in the community primarily through 1915C waivers, but can also be done through certain state plan options or potentially the 1115 waiver. In terms of the relative kind of provision of long-term care in institutional versus community-based settings, it varies across the nation. Some states have leaned very far into community-based care. Other states are still more institutionally focused, may have some work to do to kind of shift that to community-based care. But what we've generally seen is that, nationally speaking, that trend has been shifting from institutional care to community-based care. And I believe since about 2015, on balance, over 50% of Medicaid's long-term care spend has been in community-based settings rather than institutions. This is an initiative that's called rebalancing, which the federal government has been invested in since for a number of years, but most notably since 2014 through a very broad federal regulation that looked to define federally what constitutes a Medicaid home and community-based service, and then gave states a significant period of time to start transitioning some of their HCBS settings that might not have met that definition but could into compliance. Initially, that was going to be done by 2019. That's since been extended through 2023, and in part due to the COVID-19 pandemic. So as I noted earlier, the impact of COVID on the long-term care sector has been dramatic. The mortality rate has been significant, especially among nursing home residents and nursing home workers. And that subsequently led to the prioritization of long-term care institutional settings for the first round of available COVID-19 vaccines alongside frontline healthcare workers. like other providers, long-term care providers were also hit hard by the decreased utilization of their services during the pandemic. Unlike some other provider types, their utilization is not necessarily bouncing back. There's only so much that telehealth can do for in a long-term care setting. It's facilitated things like remote monitoring for individuals that live in the home or community. But at the end of the day, telehealth is not going to assist with those activities of daily living that Kate mentioned, that Kate covered. You can't use telehealth to help someone get dressed, feed themselves, and use the restroom. We've seen in the nursing home space that nursing home occupancy rates have not really, they've remained lower than in previous years. I think in part due to ongoing concern or fear around families admitting some of their members into those settings, which is prompting some federal conversations around maintaining the financial viability of the nursing home industry. But that's also has to fit into that rebalancing conversation that I mentioned earlier. So we had the longstanding goal of not being so reliant on institutional care, but also recognizing that there is a continuum of care and there will always be individuals who prefer that setting. So we have to think about federally, how do we strike the right policy balance between ensuring that option is available, but maybe not unduly incentivizing it over community-based options. In the HCBS space, again, the provider types, those providers generally just didn't have the same national profile that the nursing home providers did. So they unfortunately tended to not be prioritized for personal protective equipment. They weren't really prioritized for access to federal provider relief dollars that nursing homes had easier access to. And some of the temporary relief mechanisms that states had available to them, such as a concept called retainer payments, where states could essentially pay an HCBS provider for services that would have been rendered if the individual was still going to that setting, but weren't for whatever reason, in this case, the pandemic. But that was time limited to a maximum of 90 days. So essentially, we're well past that point. So there are still some significant financial strains on the HCBS provider community, and I think some ongoing concerns around the availability of a workforce for Medicaid members receiving services in the community. So what all this really means, big picture, is that there is a national conversation that's starting to happen right now around what is the path forward? How do we rethink the provision of long-term care nationally and within Medicaid? It's far-ranging as touching on how do we improve quality of care and infection control in institutional settings? Do we need to be making new investments in workforce and capacity and rate structures, or even making the provision of HCBS a mandatory benefit in Medicaid? Too early to say where we're going to land on this, but the ground is ripe. I see that I've got 5 minutes left, so I will, instead of covering behavioral health topic, I'll just stop here and see if folks have questions.
Yeah, thank you, Jack. And we do have a couple questions in the queue, and if we don't get to them fully in the last few minutes we have, we can follow up. But we've had one in the queue for a minute, as in for quite a while, and I'm not sure if it's for Jack or Kate, so I'm going to throw it out to both of you. What can Michigan be doing to best prepare for enhanced FMAP redetermination compliance? Is one-time support funding helpful to assist MDHHS in addressing the redetermination backlog?
Sure. So let me take that one. So the FY22 executive recommendation actually includes funding for just that. It has one-time funding of, I think, about $23 million gross. For MDHHS, that would be MSA plus the Economic Stability Administration, who helps us with redeterminations to tackle the backlog. And with that investment, we still think that it will take us upwards of 6 months to clear out all of the cases that need to be reevaluated, but the funding will be critical to helping us to meet not only our expectations for redeterminations, but also CMS's.
Great. I have the second question pulled up in the Q&A box, and I'm happy to speak to. You're on mute.
Yep, sorry. Let me throw that out to everybody. For both speakers, neither of you had a chance to cover the racial ethnic disparities in COVID-19 or in healthcare services or outcomes in general. What role do you believe the Medicaid program has in identifying and addressing disparities in healthcare? That is a lot in 3 minutes, but go and see if you can at least partially address it.
Sure. So I can start from the NAD perspective. We are doing work at the association level to be strategic about addressing what we know are some significant disparities in healthcare outcomes, both in COVID-19 and in general in the Medicaid program. That thinking in equity and also has a leadership component in terms of how do you better communicate to communities that are disproportionately impacted by negative outcomes. The role of member advisory councils and maybe better leveraging those, as well as thinking about programmatic or policy initiatives that can be done, such as collecting more granular data to inform, to have a richer data set to identify where the disparities lie and make some informed decision making, or as well something as granular as looking at kind of postpartum coverage options to address the very significant disparities in outcomes for pregnant women that fall along racial lines. So essentially, we're talking about it, and I want to give Kate a chance to discuss this as well.
Yeah, so Kathy, just like real quick. So Michigan actually does the data analytics and compilation that Jack was just talking about. We release an annual equity report, which I think highlights where there are opportunities for improvement. And we share that information not only within MSA, but within the department and our stakeholders as a call to action for having us all be mobilized to address health disparities. We also have a commitment to social determinants of health. Most recently, we've been really building up resources within our Medicaid health plans for community health workers. And the notion is that those community health workers, because they are originating in the communities where Medicaid beneficiaries reside, live, and work, that they will be able to help us in our quest to eliminate health disparities. So super quick, I could have gone further, but I know that we've only got a minute left. So thank you.
And actually, we're at 11 o'clock right now. So first of all, before Jack closes, I just want to thank both of you. We know how incredibly busy Medicaid directors are, and Jack, you must be incredibly busy supporting the states and their Medicaid directors during this unusual time. You did break up, Jack, for 1 second at a critical point. You were mentioning when the federal government has determined or has extended the public health emergency, and we couldn't hear the date you provided. Could you just quickly clarify that, and then we'll close?
So that's actually a great point. So under federal statute, the public health emergency actually has to be renewed in 90-day increments. But what the Biden administration has done by sending a letter to the nation's governors in January was provide assurances that it was their intention to renew the public health emergency for the duration of calendar year 2021. And at minimum provide states with 60 days advance notice when the public health emergency expires. So we don't have a firm end date, but we do have some commitments that we can kind of count on it to be in place at least through the rest of this year.
Great. Thank you both so very much for your time today. And Kate, I know you had other slides. Perhaps we can discuss Medicaid 201. I'm not going to ask you to commit today, but I know you'd probably like to really cover some of the Michigan initiatives, which are really interesting, exciting, and important. So I'm going to turn it back to Arnold to close us off today, and thank you both again.
Well, thank you, Kathy. And again, thank you, Kate and Jack, for taking so much of your time this morning to lead us through this presentation. Obviously, a very complicated and complex matter that really an hour and a half is not enough time. So maybe we will have an opportunity at some point to come back with another session. Again, thanks to both of you. Thank you to the Michigan Health Endowment Fund for their generous support. And of course, thank you to Kathy and the MSU Institute for Health Policy and to all of those attending. This session is being recorded and will be posted and emailed specifically to our group in the near future. Again, thank you, everyone, and have a great day.
Thank you.
Thank you.